This is a video on anti-diabetic medications. We're going to be talking about drugs used to treat diabetes mellitus by lowering blood glucose levels. Before we begin, we're going to break down the list of drug classes that we have on the left here. We have the insulin sensitizers, the insulin secretagogues, the anti-alpha glucosidases, which allow for slow absorption of carbohydrates. We have peptide analogs that serve a couple functions that we'll talk about. We have the glycosyurics, which block reabsorption of glucose in the kidneys. And then we have two random grab bag drugs that are approved for anti-diabetic purposes, but really have other primary purposes. That's a bile acid sequestrant, colesevelam, and bromocriptine, a dopamine agonist. We're going to start off by talking about insulin, which is, of course, a protein that decreases blood glucose levels. Insulin comes in many formulations. All of them break down to bind the insulin receptor, and the insulin receptor activates a tyrosine kinase receptor pathway that does the many effects of insulin. These insulin variants can be used for diabetes type 1, type 2, as well as gestational diabetes. We're going to start with the rapid-acting insulins. These are Lispro, Aspart, and Glulisine. These are monomeric insulin analogs. They are monomers in solution. They break down pretty quickly, and that's why they're rapid-acting. So the peak time here is 1 hour, and there's really no lag before these rapid-acting insulins start to take effect. So that lag is a mnemonic that can help you remember Lispro, Aspart, and Glulisine. These are used for postprandial glucose control. That means controlling your glucose after a meal. You might pop these in right after a meal or right before a meal or during a meal to help control the postprandial glucose spike. Next, we have short-acting insulin. This is just called regular insulin. It's the same insulin found in the human body. It's a dimer or hexamer in solution. It breaks down a little more slowly than the rapid-acting insulin, so it reaches its peak in 2 to 4 hours. This is administered intravenously for people who come in diabetic ketoacidosis. Next up is the intermediate acting insulin. This is called NPH. It peaks in 4 to 10 hours, so intermediate amount of time before it reaches its maximum potential. But it's not quite as long-acting as the long-acting insulin, which is glargine and detamir, which don't really peak at all. They kind of go in your body, and they even precipitate at body pH, depending on the pHs. Some of them might not even be in solution. So these don't really peak, as I said earlier. They're relatively flat, and because they're relatively flat, they're good for mimicking the basal glucose levels that your pancreas usually secretes. So in people with type 1 diabetes, they might be given a long-acting insulin that kind of keeps up that basal insulin release. Next is the biguanides. A big one here is metformin, very commonly used drug for diabetes. Metformin's mechanism of action is to sensitize to insulin. It does this by stimulating the liver enzyme AMPK. The exact mechanism of action is unclear, but it's definitely through that enzyme AMPK. This does not require functioning beta cells, so it means it does work in DM type 1 as well as DM type 2. It's more effective in the liver than the muscle at sensitizing to insulin, and that's in contrast to another drug that we'll talk about later. Metformin is administered orally. It decreases hemoglobin A1C by about 1 to 2%, which is a pretty good decrease compared to some of the other drugs on this list. We also see mild weight loss with metformin use. Some side effects include diarrhea, nausea, vitamin B12 deficiency, and the commonly tested one is lactic acidosis. So it's important to associate metformin with the risk of lactic acidosis. Metformin is contraindicated in liver, kidney, and heart failure. So if somebody's kidneys aren't working, don't give them metformin. Metformin is first line for diabetes type 2, in addition to, or sometimes slightly after, weight loss and exercise. Next is the thiazolidinodones. These are also called TZDs, or the glitazones. Two drugs that are worth knowing are pioglitazone and rosiglitazone. These, like metformin, sensitize to insulin. They increase the number and sensitivity of insulin receptors. They specifically bind to the PPAR gamma receptor. That's the peroxisome proliferator activated receptor, gamma receptor. They are more effective in the periphery, this is the muscle or the fat tissues, than the liver, unlike metformin, and they do not require functional beta cells again, so this could be used in type 1 and type 2. These glitazones are also administered orally, and they decrease HbA1c by 1 to 1.5%, also a pretty good decrease. These are uncommon, these are unpopular because they cause mild weight gain, which is usually the opposite of what we're trying to do in DM patients. They can also increase LDL, which can put you at risk for coronary problems. They're also pretty expensive and slow onset, so it's easy to understand why these are less popular than metformin. Side effects here, as we said earlier, are weight gain. We see some edema. We also see heart failure, liver toxicity, and fractures of the bones. But these are safe with renal failure. So if you have a patient with DM2, has some renal failure, you might not be able to give them metformin, but you can give them one of the glitazones. Next up are these two categories, which are the insulin secretagogues. They increase the secretion of insulin directly. They both tend to decrease HbA1c by about 1 to 2%, also pretty effective. Side effects here are that they cause weight gain and they put you at risk for hypoglycemia, which kind of makes sense. If you're forcing the body to release its stores of insulin, it's possible that too much insulin would be released and you can become hypovolemic. Some people also have allergies, specifically to the sulfonylureas. People who have sulfa allergies might not want to give them the sulfonylureas, and they're administered orally. So let's talk about the two groups, sulfonylureals. These are broken down into first generation and second generation. The first generation sulfonylureas are tolbutamide and chloropropamide, and the second generation sulfonylureas are glipizide, glyburide, and glimepiride. These last three, second generation, all start with GL and end with IDE. That's how I remember them, second generation sulfonylureas. These bind to the sulfonylureal receptor on the ATP-activated potassium channel of beta cells, and they do require functional beta cells. So they bind to a potassium receptor, they block it, forcing those beta cells to depolarize, which makes the calcium channel on those cells open up, calcium rushes in, and it releases insulin. It's worth looking into the release mechanism of insulin to understand this. So they block that potassium channel, calcium influxes into the cell, and it activates insulin release. Similar mechanism of action in meglitinide. So these are ripaglinide, nataglinide, so they end in glinide. These bind to another receptor to block the potassium channel. So it's a different receptor on the same potassium channel. They have the same mechanism of action after that. So they block the potassium channel, which leads to calcium influx, and that, again, activates insulin release. The second group, the meglitinides, have faster onset and a slower duration, and they're also more expensive compared to the sulfonylureas. Next drug is anti-alpha glucosidase. These two drugs are acarbose and miglitol. Mechanism here is that they slow absorption of carbohydrates in the proximal gut. Alpha-glucosidase is an enzyme that hydrolyzes carbohydrates in the brush border of the gut. So if you inhibit this enzyme, you're going to slow the absorption and slow the breakdown and slow the absorption of carbohydrates in the gut. So you're going to delay carb breakdown and thus delay carb absorption. You're also going to decrease postprandial hyperglycemic spikes using these drugs. They're again administered orally. You want to get them into the GI tract. They decrease the HbA1c percentage by a modest amount, 0.5 to 1%. And one of the big cons of using these drugs are the severe flatulence and other GI disturbances that you get by using this, which kind of makes sense. You're kind of feeding your gut bacteria a bunch of glucose that you're failing to absorb. So people tend to have gas, and that causes poor adherence to these drugs. They're also pretty expensive. Next group of drugs is the incretin mimetics. It's worth reviewing that the incretins, which are GLP-1 and GIP, are gut-derived hormones that have a couple functions. They stimulate insulin release, they inhibit glucagon secretion, and they slow gastric emptying. They also promote satiety. So we can stimulate incretin release by eating, by stretching the stomach and the gut, and it's secreted by the gut. There are a couple analogs to these incretins or incretin mimetics that we can administer as medicine to get these same four effects. These GLP-1 receptor analogs are exenatide, liraglutide, and dulaglutide. So they mimic that incretin and they produce the same incretin effects. which can result in weight loss, which can be desirable to patients. Next, we're going to talk about an enzyme called dipeptidyl peptidase 4, which is the enzyme that breaks down these incretins. So you can imagine that if you inhibit DPP4, you're going to have your endogenous incretins around for a longer amount of time. And that's exactly what DPP4 inhibitors do. They increase the blood concentration of your incretins. So the drugs that do this, the drugs that inhibit DPP4 are the agliptins. So we have sitagliptin, we have saxagliptin, and linagliptin. These are the DPP4 inhibitors that block the breakdown of incretins. And these are also administered orally. Next group of drugs is the amylin analogs. So there's a synthetic amylin analog called pramlintide. Now, amylin is usually a molecule that's co-secreted with insulin in the body. Some people call it the second blood glucose decreasing drug. So it has the following effects. It inhibits glucagon secretion, it slows gastric emptying, and it promotes satiety. So these amylin analogs act like the endogenous molecule amylin, and it has these three effects. The synthetic version is called pramlintide, and they decrease HbA1c by a modest amount again, 0.5 to 1%. Side effects here are nausea and hypoglycemia. These can also promote moderate weight loss, which can be desirable. And these are also administered orally or subcutaneously. Next is a group of drugs called the glycosyurics. These promote renal secretion of glucose, renal excretion. They are excreted. Glucose is excreted through the kidneys. So there's a transporter in the distal convoluted tubule there's a transporter in the proximal tubule called the sodium glucose cotransporter 2. And if you kind of promote this channel's activity, you're going to absorb more glucose. If you inhibit this transporter's activity, you're going to be dumping more glucose into the urine. You're going to be wasting glucose, and that's one method of lowering your blood glucose level. So if you inhibit the SGLT2 cotransporter, you're going to have an effect of decreasing blood glucose, and that's what these drugs do. So we have canagliflozin, dapagliflozin, and empagliflozin. Now, I remember these in that they all have flow in them. They all end in flozin, and that's because they allow for the free flow of glucose through the renal tubules and out in the urine. These also decrease HbA1c by a modest amount, 0.5 to 1%. And there's a whole list of side effects that are related to peeing out excess glucose here. It puts you at risk for UTIs, especially in women. You can get vulvovaginal candidiasis, which is yeast infections in the vagina. You can get glycosuria, which is kind of the point you want to be peeing out glucose. You can get renal failure, and this can also decrease your blood pressure, cause dehydration, and cause hyperkalemia. So all kinds of other kidney effects that you get from purposely peeing out the glucose. These also promote substantial weight loss because you're essentially ridding your body of sugar through your urine. Next is a drug that's not primarily used for diabetes, but it is approved for use in diabetes mellitus. This is colesevelam. It's a bile acid sequestrant, and its exact mechanism is unknown. It decreases HbA1c by a very modest amount, 0.3 to 0.4%, so not the best on this list at all. Some side effects for this drug are constipation, dyspepsia, nausea, and hypertriglyceridemia. Next is bromocriptine, which is a dopamine analog. This, again, is not primarily used for diabetes, but it has been approved. The exact mechanism of action is unknown, but it also decreases HbA1c by a very modest amount, 0.4 to 0.5%. Side effects here are headache, dizziness, nausea, and vomiting. This has been an overview of drugs used to treat diabetes mellitus. I hope this was helpful, and thank you for listening.